23-year-old female. In 2019, she was diagnosed with left parietal cavernoma due to headache. Conservative management was established at that time. In 2020, sudden severe headache, and she was neurologically intact at the admission. Here is the MRI of the patient, axial cut T1. It shows hematoma in the subcortical region of the left parietal lobe. The image is suggestive of cavernoma. And the cavernoma is also surrounded by probably edema. And my question is, how can I approach this lesion? So here we can see the arrow is indicating the junction between the postcentral sulcus and the intraparietal sulcus over this region here. So this might be a good access to getting to the cavernoma. So this is a 3D multiplanar reconstruction, coronal, sagittal, axial cut. I want to get to this intercepting point. I want to get to this sulcus to access the cavernoma. I want to use this sulcus to reach the cavernoma over here. So the patient was placed in prone position. So this is the exposure after the dural opening. For me, this is the postcentral sulcus, and this will be the intraparietal sulcus. This is anteriorly, this is posteriorly, and this is towards the sylvian fissure, this is toward the midline. So let's see the video. The first step is to open the sulcus. So I can create space to go to the bottom of the sulcus and access the cavernoma. But in order to protect the vein, I have to dissect the vein and dissect, for instance, this small arterial branch, so I can mobilize both the vein and also mobilize the cortical arterial branch. So I'm cutting the arachnoid membrane, dissecting the sulcus. So this is postcentral sulcus is a very deep sulcus. I have placed a gel foam, piece of gel foam, to keep the sulcus open. And now I have cut the arachnoid on this side of the vein, and now I cut an arachnoid on that side of the vein. Gel foam to keep the sulcus open. This is a navigation cistern, and now this is a fibrin glue to protect the vein. Now I have located the cavernoma using navigation, and now you can see the blood coming out. The suction tube I used for this case was 3 French, very tiny cannula suction tube. So it fits in a very tiny space very well. And then the surgery of the cavernoma is just regular removal of the clot, removal of the cavernoma. There is a DVA in this area. I have to preserve it because DVA is not abnormal. It's the variation of the venous drainage pattern of the patient. Whenever possible for the cavernoma removal, it is good to remove also the halo of a hemosiderin. Although this patient has no complaint of seizures, only headache, but in places where you can do a little bit additional removal, it is good idea to remove the halo of hemosiderin that surrounds the cavernoma. So just working around the cavernoma, cutting and coagulating using the space gained after opening the postcentral sulcus. It is the removal of the cavernoma, hemostasis, probably remaining hemostasis, maybe small piece of cavernoma was left, so I have to remove it after inspecting the surgical cavity. Now I think it's clear. This is a final aspect of the surgery. Hemostasis. You see the vein was very well protected by fibrin glue. And this is a final aspect after the removal of the cavernoma. She remained neurologically intact after the surgery. And this is the postoperative MRI showing the total removal of the cavernoma.